Good morning, Jenny.
Morning.
How are you doing?
Good. How are you?
I'm good. Nice to see you.
Nice to see you as well.
So while we wait for the others to sign on, do you want to just try sharing your screen?
Sure. Is that working?
Yeah. So right now you're in presenter, like in the normal mode. So just hit play. So you go to the slideshow.
I think I switched.
Yeah. Well, actually, no. You're in presenter mode now. Are you using two screens?
I am. So I think I just swap it like that. Did that work?
Yeah. There you go. Perfect.
Oh. Okay.
Okay. Perfect. And do you have any video?
I don't have any video. No.
Okay. So that's perfect. Okay.
And then I'll stop sharing. And then I don't have any polling questions because I just ask questions. Do I have to do anything? Because I know usually.
Yeah. So what I'm going to do is, I saw your email. What I'm going to do is upgrade the U of T resident status to allowed to talk. And what I'll do is I'll give them a heads up too, because this is the more traditional grand rounds format, but we haven't been doing it recently. But it is great, so I'm glad you guys are doing that. But they should be able to speak and answer questions.
Okay, thanks.
What you might want to do in order to get participation, because no one's going to volunteer. Okay. Yeah. What you might want to do is target the questions. I know it's a little awkward as a PGY2, but you can just say, can one of the PGY4s or one of the PGY5s help with this one, right? Okay. And that way you're not calling on a specific person, but at least you'll get some participation.
Okay, thanks.
And the other person who's given a talk today is Shabo, is that right?
Yeah.
Yeah, okay.
I don't know if we discussed who's going first though.
Okay, we should discuss that soon.
Yeah.
Once he gets on.
Mm-hmm.
So where are you now, Jenny?
I'm at St. Mike's right now.
Oh, okay, nice. How's that going? Shabo's here.
It's pretty good, I think. I'm just getting used to different sites.
Yeah, it's busy.
Mm-hmm.
Hello.
Good morning, Shabo. How you doing?
Yeah, I'm good.
Okay, so we've already gone through Jenny's, but do you want to try sharing your slides just to be sure?
Okay, sure. Let me open my. How do I share a screen?
So at the bottom, there's a green arrow.
Yeah, got it.
Just hit that.
Okay.
Okay, and just try to click through a couple times. Yeah, perfect. Do you have any video?
No.
Okay,
just photo.
That's fine. Perfect. Okay, that's good. And then just hit stop share.
Great.
Perfect. Now, I was talking to Jenny about this before, but if you have questions for the audience, we will have the U of T residents unmuted. But instead of picking on a specific person, you may want to just throw out the question to a year.
Yeah. Sure.
Okay.
All right.
Oh, Oh, there he is, the man.
Yeah, I'm in the, can you tell where am I? I'm in the
Where?
wet lab.
That's right. You're in the wet lab. That's right. I knew I
Yeah,
recognized that
so,
place.
because I'm operating.
Yeah, yeah.
Yes.
I'm on the 6th floor.
We're using the same network then.
That's right. Don't crash it.
Yeah. How you doing, Jenny?
Good, how are you?
Long time no see. Where are you based in?
Right now I'm at St. Mike's.
Oh, St. Mike's. Yeah. It's is it busy?
And there's some days where it is busy. Yeah. So I was just saying, I'm just getting used to how everything runs there.
Yeah, yeah. Once you get used to it, it's not a bad side. It's very everything's well organized and
You lots of hands-on experience there.
Mm.
yeah.
Okay, Larissa's here. Good morning, John. Good morning, Larissa.
Oh, okay. Now I'm logged on. Good.
Hey.
Okay, it takes a minute. Hi.
How are you? Now,
Good.
Larissa, just before we do anything else, do you have slides that you want to just test by hitting share screen at the bottom? Are you sharing slides as well or no?
Oh, no, I'm not.
No,
So
okay,
no,
okay,
it's the
perfect.
residents because they the
Yes.
cases were fairly long, so I'm
Yes,
not
okay.
going to share slides. So one of the things I was going to ask is, are you so as we go along, there's a couple of spots where we're going to ask questions of the residents,
Yep.
and then Ashabo has some polling questions. So do you so should I go ahead and stop, or how have you run it in the past, or do you want to stop, or
No, I think it's nice if you do actually, as the faculty person. And what I was telling these guys is, in this format, it's a little easier if you just call out a year instead of a specific person. So if you have if you have a question, and then if no one answers, you can maybe narrow it down to a specific person. But generally, with the year, we get an answer, and so it's nice. Now, who's going to go first?
Residents. I don't have a list of residents in front of me.
I can definitely help you out. I can
Okay.
definitely help you out.
I'll
Don't
go
worry.
for the year. You
Yes.
can name the person.
Okay. We'll see if we get someone with the year first. Now, who's going to go first, Jenny or Shabo?
It doesn't matter.
Yeah.
Shaba, did you go first or second last time you presented? You went second, right?
Oh, 1 second.
Do you want to go first?
Yeah, sure.
Okay.
Yeah.
Okay.
So that I can join the OL sooner, I guess.
You can get there on time then. Okay. So we have two presentations. I'm not doing a presentation because the presentations were fairly long, actually. So we're hoping to leave about 5 to 10 minutes for questions at the end. I think there'll be more time for questions for the for Shabo's presentation, but we would like to. I think there's some interesting discussion for both presentations. So. Do we have a way of, if we need to move along and kind of wrap up, how do you usually indicate that to the presenters, Emma?
Yeah, so
just send me a chat message.
Well, the other option is there's a chat box. This is probably easier. There's a chat box, and so if you click the bottom of your screen next to where it says share screen, there's chat.
Yes.
And you can send a message to all panelists, and so that's an easy way to communicate amongst this group.
Okay.
And that way everyone's on the same page.
Okay. And I think Nupura was going to join as well. So when
I'll keep an eye out for her.
Can you make her a panelist as well?
Absolutely.
Okay, sounds good. So at the end, are you going to monitor questions from the audience?
Yeah. I can definitely do that. You guys feel free as well. But if I see questions in the chat box, I will try to get them to you guys at an appropriate time.
Okay, and so questions we'll do mostly at the end, I think, from the audience, but we'll engage the residents during the presentation.
Yeah.
All right, sounds good.
Nupra is here. Good morning, Nupra.
Oh, I don't see.
Good morning.
Oh, she is. Okay.
Morning, Dr. Bakshi.
Good morning.
Thank you for
Morning.
sending me the photo. I added it.
Oh, you did? Oh, wow. That was some last minute down to the wire changes there. Okay.
But it's not as impressive as my internet photos.
Yeah, you know what? But I was actually impressed. I mean, that caused them to want us to him to go to the ER. So I think our
Yeah.
threshold for,
It has like subtle diseases, and then
yeah. So, I mean, I think it's a good learning point that even we might dismiss it, but it's probably worth at least saying, touch base with your rheumatologist because they would take it more seriously. I'm going to turn off these overhead lights here.
John's just having some technical difficulties. I think he's restarting his Zoom. We'll give him just a minute.
I have a quick question for Shabo, if I could.
Yes.
Are we just going to do the polling questions, Shabo, or are we stopping to ask residents questions?
maybe I can ask one of the residents to come up with differential diagnosis and describing the photos and the workup stuff.
Okay.
So to make a short pause to have them involved.
Okay, sounds good. Yeah, I didn't know whether you had discussed that previously, and I didn't ask you. As I know you've been so Nupra prepared. Well, Nupra and Shabo were kind of more involved in the first case. So Nupra, jump in if there's anything that you want to add or comment on.
No problem.
All right. So I think John's here. He was having some technical difficulties this morning. John, you there? Okay. Maybe he's still having those. Maybe we get started just in the interest of time. I do know the presentations may be a little long. So guys, welcome back to the weekly U of T Grand Rounds. It's my privilege to introduce our faculty person this week, Dr. Larissa Dershko, who is the chief of the uveitis service for our department in the city and on staff at both St. Mike's and St. Joe's. And just an absolute privilege to work with her and have learned from her as a resident. I do see John here. I know he may want to say a couple words and then we'll get started.
Yeah, sorry. For some reason, my Zoom crashed multiple times joining today. I had to reboot my computer. So yes, it's my absolute pleasure to welcome Larissa. She has been wonderful asset to uveitis in our department. She did her training here at U of T and then her fellowship training at McGill. And great. Now can you take this back? You're honest. Morning is not going well. Anyway, she's a fabulous teacher for our residents, and she's very active in research in uveitis, and is actually leading a resident multidisciplinary and translational research project on PCR utilization in anterior uveitis and imaging in both PIC and retinal vasculitis. She is a provincial and actually global expert. She leads an Ontario task force in uveitis and has established standardized criteria for immunomodulatory treatment for uveitis under the Ministry of Health Exceptional Access Program. She's developing a communication tool between ophthalmologists and rheumatologists, which will also be used in the registry. She's also our past president of the Canadian Uveitis Society, and she's done much to increase awareness of uveitis at both the provincial and federal government levels. She's also our Canadian representative on the International Ocular Inflammation Society for the last 7 years. She is also a close personal friend of my wife since childhood, and she and her husband are close personal friends of both of ours now. And so thank you very, very much, Larissa, for joining us and helping out your friend.
Thank you very much. So I'm going to pass over the stage here to the residents in a moment. I will stop during their presentations. We'll discuss the cases, but thank you very much for that introduction. I think it's mostly the residents that are really on the stage today. So we're going to start with Shabo. With no further delay. And the topic today is mysteries in uveitis. And we're continuing along with our first grad rounds in uveitis, which was also mysteries in posterior uveitis about a month ago, which I thought was excellent. So Shabo, you go ahead, please.
As Shabo is just loading a slide, just one housekeeping thing for today. The U of T residents will notice that I've unmuted them. Dr. Dershko and the team do want some audience participation today, so they will be asking for that. So let's try to give them some feedback and some answers.
Okay, Good morning, everyone. My name is Xiaobo Lei. I am a fourth-year ophthalmology resident at U of T, and my screen is supposed to be on, and everybody can see it. Yep.
Yes.
Let's go ahead. Okay, so this is the case I'm presenting today. He's a 23-year-old, previously healthy male, presented to the eye clinic with 3 days history of acute onset floater, distorted vision, and hazy vision. And he said this symptom developed after he's been having like flu-like symptom, fatigue, fever, and lingering retrobubble headache for months. And then after that, he suddenly developed vision symptoms. He's previously healthy. His past ocular history include myopia. And interestingly, the referring ophthalmologist also mentioned that he had iritis in the left eye that was treated with topical steroids 7 months ago and has no ocular history for surgery or any ongoing medication for the eye. And a bit of a social history. He was born and raised in Canada. He worked as in a car dealership. He admits that he's sexually active with multiple female partners. He does not smoke. He only drinks socially and occasionally. He's a cat owner, and he endures being scratched by his cats multiple times over the last 6 months. And he also offered a history of traveling to Ohio 6 months ago, and he stayed in a log house there. Family history, he said his grandfather lost vision in one eye for unknown reason. It could be just cataract. And obviously, I'm offering all this information to confuse my co-residents, from whom we're going to pick one to tackle this case shortly. And then his family is from Greece, Cyprus, and Syria. On examination, and the visual acuity is not bad, but he said it's hazy, 20/30 in the right eye and 20/20 in the left. IOP is normal, pupil is normal, and anterior segment exam is pretty unremarkable. As you can see from these nice photos, nicely dilated pupil, clear cornea, and except that some anterior vitreous cells noticed bilaterally. And here is the dilated fundus exam. I'll just go over this. So as you can see, the media, the vitreous, it looks a bit hazy in the right eye compared to the left eye. And then most strikingly, there is, can you see my cursor? Can you see my mouse cursor?
Yes.
Yep.
Okay, yeah, you can. Okay, so there is a peripapillary retinal whitening lesion inferior and temporally to the optic disc. And in the macula, it shows some cystoid macular edema, very mild, and subtle subretinal fluid as confirmed on the OCT scan. Here's the IVFA, as you can see. Beside the peripapillary lesion that shows hyperfluorescence leakage, there is very diffuse and maybe 360-degree peripheral staining of both arteriola and venous. And it involved both eyes with some diffuse veil-like leakage and vessel staining. And so in summary, so this is a 23-year-old previously healthy male with right eye, posterior, and intermediate uveitis, anterior vitreous cells, right, and peripheral vasculitis. He has retinitis, it's a retinal whitening lesion, vitritis, and peripheral vasculitis with CMV and subretinal fluid. On the left eye, there are also peripheral vasculitis with recent history of anterior uveitis. Now I would like to invite one of my co-residents to come up with a differential diagnosis.
So let's ask maybe one of the PGY4s to provide a differential diagnosis for us. Any volunteers? Okay, who's
Maybe
logging?
I'll help you out.
Okay, thanks.
Okay, so PGF4 is I see Aaron Chan is here. Let's start with there. But we will ask others as well to help out.
Yeah. Hey, good morning, guys. I'm here. I just started wrangling my kids out of the way. So Shavo, thanks for that case there. I like how you threw a whole bunch of red herrings there to try to confuse me with potentially the Ohio being the POHS and the cat scratch disease would be in the differential. But I guess with the posterior uveitis and the vitritis, I'd start off with common things like sarcoid, syphilis, TB. I'd want to rule out. I'd want to rule out viral causes of posterior panuveitis. And then with the vasculitis, I guess that opens up a whole bunch of different differentials as well. Being both a phlebitis and an arteritis, it could be quite wide. So infectious causes come to mind. Different white dot syndromes come to mind. I guess Behçet's, Susak's, Irvan's, Heels, different things would come to mind as well. I think it's quite broad at this point. The fundus photos wasn't very, other than the peripheral vasculitis, and it's very quite broad for me. So I'm not sure which way I would lead. I'd probably have a pretty big shotgun approach and send out a lot of different things. If any other residents want to pipe in, I'd be more than happy.
Any other? That's very good, Aaron. It's very complete. There's a couple of infectious causes that we always have to remember when we consider posterior uveitis. Is there
Toxoplasmosis and toxocariasis? I'd also include toxo being the most common thing.
Exactly. Yeah. And another category, which doesn't have all the features, but there's another category of infection to think about as well.
Did I say viral retinitis? And I'm not sure if I mentioned.
Here, but that's what I was looking for.
Okay. So yeah, like ARN, POR, and CMV, I would consider those things as well.
Yeah, I mean, it's not typical of an ARN, but we could consider, could this be something early? We should keep it there in our list. Anybody else with any other ideas? There's a couple of other non-infectious causes.
I would probably add the other vasculitides other than Behçet. So I would add ANCA, so GPA, other like polyarteritis nodosa, lupus.
Yes, yeah, that's very good. Okay.
Yeah, that's very good. So connectively, you pretty much mentioned all of that. So, well, I mean, basically in uveitis, we often send out a whole bunch of tests and all come up negative, and we treat it with steroid. But first of all, we need to rule out some infectious cause, and because there's clear etiology in infectious cause, and usually it's curable once you treat it properly. And in this case, include Bartonella, it's a cat owner and being scratched multiple times, and syphilis is his sexually active multiple partner, and Lyme disease, toxoplasmosis, and TB. Toxo and TB, syphilis, you need to rule out basically in any uveitis, and then HIV, herpes virus infection. And in non-infectious category, obviously, we have the idiopathic big category, and then we have to think about disease with systemic association, because those are diseases with higher chances of mortality. And differential diagnosis include plasmapenitis and MS, SL, lupus, sarcoid, Behçet's, ear disease. So I won't go through the details of these lists, but you guys mentioned pretty much all of it. Very good. So as Aaron suggests, we will send out a whole bunch of tests. These are the tests we sent for this case. And the results show, ta-da. So your analysis has some protein and RBC in the urine, and the CRP is elevated. So that's a non-specific marker for systemic inflammation. And most interestingly, is Bartonella-Hansley IgG is positive. But so now we have a clear suspect in this case, this guy. By the way, that's my cat. So, well, too bad I can't hear the laughter.
I was laughing. That's funny.
Yeah, that's my cat. I know she looks so innocent, and she's a good COVID-19 lockdown companion. I got her during the lockdown to entertain my kids, and then obvious. So of course she has scratched me multiple times. Maybe I'll develop retinal neuroethnitis later on. But the good thing is. Bartonella-Hansley is readily treatable, so which lead to my first open poll question of today. Which one of the following option is a empirical treatment for ocular bartonellosis? A, doxycycline, B, azithromycin, C, rifampin, D, ciprofloxacin, and E, all of the above. All right. Okay, so about 45% of people choose answer E, all of the above, which is correct. Bartonella-Hansley, it's a mild infection, most of the cases, and then it's self-limited. And the benefit of antibody is not fully established. A wide range of antibody can be used for treatment of ocular bartonellosis. Doxycycline, 100 milligram twice a day, give very good tissue penetration intraocularly. And azithromycin can be used in children. It has been shown to relieve the lymphadenopathy. Rifampin can be used alone or added to as a junction to doxycycline or azithromycin for severe cases. Ciprofloxacin has also been used. So the answer is all of the above. Okay, so our initial diagnosis is ocular bartonellosis, and then he was treated with Durezol 4 times a day in both eyes, and we give him doxycycline 100 milligram BID for a course of 4 weeks. And he responded very well. As you can see, he initially presented in March 2017, and then in 2 months, in May 2017, his CME is gone, and the hotspot corresponding to the peripheral lesion on the OCT is also resolved. His OCT looks pretty normal in 2 months, and the vision is 20/20, and the patient's happy. So things are looking quite good at that time. But the patient continued to experience persistent headache, and 6 months later, he had a flare-up of flu-like illnesses, fever, fatigue again, and he had a flare-up of eye symptom, including hazy vision floater in the left eye this time. And at this point, a repeat Bartonella IgG is negative. And at that time, we have had the infectious disease console at the time.
Sorry, Chabot, can I interrupt you for a second?
Sure.
For those of us who don't test this stuff regularly, are there IgM and IgG tests for Bartonella? Was the first one an IgM? Or can you only test IgG, so you don't know if it's a past or current exposure?
As far as I know, I only see IgG test result in the file. I'm not sure if this is IgM. I assume there is one.
I think they usually test IgG for Bartonella. Perhaps if it was positive, they would test IgM as well. And I didn't look at these results. I wasn't involved in the case. Dr. Bakshi, do you have any comments about that? Do you remember?
Yeah, so they just went on the IgG being positive. It's not like toxoplasma where the IgG routinely remains positive regardless, and then it's only during the initial exposure where the IgM would be positive. So per ID, this would actually indicate infection or not, right, as opposed to toxo. So even when the IgG is positive, they didn't report an IgM.
I don't think they do IgM. Sorry, I just wanted to add, I don't think that public health does IgM for Bartonella. I called and asked many times, so it's not routinely done. So in this case, I think for diagnosis, it's mainly the titer of the IgG, which strongly suggests the infection.
I just wanted to point out, IgG, the isotech switching happens within 5 to 7 days of the initial exposure to Bartonella. So IgM is positive initially, but the IgG response actually mounts pretty quickly.
Okay.
That's very helpful.
Yeah, thank you so much for the input. And then at that moment, we had a infectious disease consult, and their opinion is that the initial IgG titer of Bartonella is pretty low. It's 1 to 64. And then it's neither sensitive nor specific for Bartonella infectious disease. And so basically they don't support the idea of that this might be a Bartonella infection in the eye. All right. So this is a zooming view of the IVFA at the time of flare-up of the left eye. You can see that there is a subtle, I circle it with a red circle. There's a subtle peripapillary deep choroidal-retinal lesion, which corresponding to a hyperfluorescence leakage on the late phase of the IVFA. And because he's continued to experience headache symptom, and we also send him to neurology for a consultation, and their finding, their impression is that the patient have had persistent non-specific headache. They didn't find any other neurological deficit. Their impression is that the patient may be a victim of systemic inflammatory conditions, and they recommended a head MRI and MRA. And here's the MRI. And I just read it. So the MRI shows focal non-enhancing hyperintense T2 lesion in the left thalamus. And there is no other brain parenchymal involvement. And the appearance is non-specific and may be associated with autoimmune inflammatory process, including prior vasculitis, infectious etiologies, or demyelinating disease. So there is a lesion, T2 hyperintense lesion in the brain, but their impression is that this is quite non-specific. And the MRA of the head and neck is within normal limit. So, so we've had a case with recurrent pan-uveitis, I will call it, and because there's anterior history and anterior uveitis and posterior uveitis as well. So recurrent episode of pan-uveitis with CNS involvement. So it's definitely quite concerning, and it triggered more detailed interview of the patient. And on further history, the patient endorsed that he's had recurrent oral ulcer since he was a child. So this is an internet photo, not the actual photo of the patient, but on examination, he does have multiple oral ulcers at the time. And he also mentioned that he has infrequent episode of skin lesion. It's painful, like little wet bonds on his chin and neck. So this his actual photo. You can see this multiple erythematous acne-like posture on his neck and lower leg. And he denied history of genital authors. Given this new information and the fact that the family is from a endemic area of the Behçet disease, so we tested HIV B51, which shows positive, and given all this new information, so we revised the diagnosis to Behçet disease with mucous membrane, skin, and ocular involvement. And we treated him, we initiated treatment with prednisone, I think it's 40 milligram daily, along with azathioprine, Imuran. And then he responded quite well initially, but once as we tapered the prednisone down to 10 milligram, and he had another flare-up, so infliximab was eventually added to the regimen. And this is his latest follow-up photos. You can see the media is quite clear, there's no vitritis, and there's no inflammatory lesion on the retina, and IVFA didn't really show any vasculitis activity. So things are doing quite well. And then a repeat MRI shows resolution of the left thalamus lesion. As you can see, the green arrow sign is gone in 2018, and everything is within normal limit. Okay, so a little bit background information about Behçet disease. It's a chronic relapsing occlusive vasculitis involving multiple systems of unknown etiology, and uveitis related to Behçet disease can affect both anterior and posterior segment of the eye. And the diagnosis of Behçet disease is really a clinical one. So it's a syndrome, and the diagnosis is based on the constellation of symptoms and the presence of multiple system findings. So here's the second question of today. Which of the following is the most consistent feature of Behçet disease? A, recurrent oral ulcer, recurrent genital ulcer, ocular inflammation, skin lesion, or a positive cutaneous pathogen test. All right, so the majority of the audience pick recurrent oral ulcer as the most consistent feature of the Behçet disease, which is correct. Actually, oral ulcer is the most common symptoms of Behçet disease. Most people will have it. If you are considering Behçet disease, but the patient don't have oral ulcer, you better think twice. Actually, in the international study group for Behçet disease diagnostic criteria for the disease, recurrent oral ulcer happening happening 3 times over the last 12 months period is required item to establish diagnosis of Behçet disease. And then with recurrent oral ulcer, along with 2 other findings among recurrent genital ulcer, ocular inflammatory, skin lesion, and pathogen test, you can establish diagnosis of Behçet disease. There's another like Japanese diagnostic criteria, but it's less commonly used in international community for of uveitis specialists.
So just a comment there about that rash that he had on his neck. So did you think that was a pseudofolliculitis? Was that what you were looking at?
Yeah. So to me, it looks like a little acneiform, maybe pustule.
Yeah, so he had about 3 of the features. And in his situation, he exhibited 3 features of Behçet's disease, we could say, right? The ulcers, the uveitis, and the acneiform lesions.
Yeah, so that's why we diagnosed with Behçet disease with mucous membrane and skin and eye involvements. So he definitely—
And also CNS, I guess. He had the brain lesion also.
Yeah, well, CNS is consistent with Behçet disease, which I will talk about later on. But CNS involvement is not listed on the diagnostic criteria, but definitely can happen. Okay, so Behçet disease ocular finding is very variable. It's a wide range of manifestations, but there are certain patterns of ocular manifestation that are suggestive of Behçet disease. I call them like characteristic for Behçet disease. First, non-granulomatous anterior uveitis with like smooth layer, non-sticky hypopyon that shift with gravity. Non-sticky, you know, in a corneal ulcer or HLA-B27 related anterior uveitis, there's a lot of fibrin and hypopyon. So the hypopyon will stick to the bottom of the angle. But in Behçet disease, those are basically leukocyte infiltrates. So they are quite smooth. If you move the eye and tilt the eye to the side, the hypopyon will shift. And that's quite suggestive of Behçet disease. And the other pattern is it's non-necrotizing. It's necrotizing retinal vasculitis affecting both arteries and veins. And that can give you retinal hemorrhages, retinitis, BRVO with variable vitritis, and CME. So here's a photo illustrating the smooth layer non-sticky hypopyon. So this eye, you can see the inferior hypopyon, and we ask the patient to slip on the side, and for like 30 minutes, then the hypopyon will shift to the medial side, and then you ask the patient to come out for the photo. You can see the little tail of like lens sliding hypopyon, like shifting towards the inferior bottom again. So that's the characteristic anterior uveitis related to Behçet disease. And then here's a photo, array of photo illustrating again in photo A, non-sticky inferior hypopyon, and then retinitis with retinal hemorrhages and like segmental retinal vasculitis, retinal hemorrhages with vitritis, and occlusive BRVO with vitritis are very suggestive of Behçet disease. So well, I show this slide, try to hammer in the patterns of posterior segment involvement that is characteristic for Behçet disease to your brain. There are other variants of ocular manifestation, including episcleritis, non-ischemic vasculitis can happen, and then they can be they can involve the optic nerve as well, and it can show like acute optic neuritis, and then later on can develop into optic atrophy. Papilledema can happen due to sinus thrombosis. Some knowledge point about the epidemiology of Behçet disease. So it's believed to be, well, it's also known as the disease of Silk Road. It seems to be spreading from the Mediterranean area, Middle East, to West Asia, to China, and then to Japan, which is corresponding to an ancient silk trade route. And then this is a more modern map. Again, you can see in Turkish, it's very, very endemic. There is over 370 cases of prevalence in per 100K population. And then it's big in Middle East, it's big in China, and definitely Japan as well. North America is considered non-endemic area. In the United States, there are only 5 persons suffering from Behçet disease per 100,000 people. And then I couldn't find any data for Canada, but I assume that's pretty similar to United States because we're both immigrant countries. interestingly, in the endemic area,
Chabot, you're going to have to wrap it up. We got the same time for the second presentation.
All right, sorry about that. So in the endemic area, Behçet, the prevalent disease is similar across all ethnic groups. So basically, I'm trying to say that there is some environmental, it has been suggested environmental factor contribute to the pathogenesis, and the people in the non-endemic area usually show milder disease, and our patient is in keeping with this notion. And then neurological involvement, about 10% of Behçet disease have CNS involvement, and then 10% of new Behçets have ocular involvement, and 30% of ocular Behçets with have CNS involvement. Headache is the most common symptom for CNS involvement, and the lesion is most commonly seen in brainstem, basal ganglion cell, deep hemisphere, white matters, and our patient definitely fit into this description. And the non-parenchymal involvement most commonly shows venous sinus thrombosis. The third question, very quick, and then which is the first line of immunosuppressant treatment for Behçet disease? And the answer.
So in the interest of time, you can just tell us this one. Thank you.
The answer is A, is azaflurane. So it has been shown in clinical trial to be able to preserve vision, treat arthritis and skin and skin lesion as well. And cyclosporine, which is a T-cell modulator, has also been used in smaller case series, but it has nephrotoxicity. Tacrolimus is less toxic to the kidney. It's used in Japan, and cells have also been used. But most of the European expert panels suggest using Imuran as a first-line immunosuppressant therapy for that. Summary, represent a case of Behçet disease with very mild ocular inflammation that was initially treated for cat scratch disease. Later on, he developed CNS involvement, and a careful review of history and targeted workup lead to a revision diagnosis of Behçet disease. So this highlights the general principles of the uveitis management. We always think about root out infectious disease and disease with systematic involvement. Thank you very much.
Thank you, Chabot. That's an excellent presentation. So I think we're going to move right along to Jen's presentation. Maybe just while Jen is loading her presentation, I'll mention, so it's in the chat, there was an interesting discussion there about whether that was really Bartonella or not. It probably was Behçet's, of course, and Behçet's can present in a variable way, as can Bartonella, and probably it was the Durezol that actually helped to treat the CME. So Jen, you're next. So this is also a very interesting case. So go ahead, Jen.
Good morning, everyone. My name is Jen. I'm one of the PGY2s, and I'll be presenting this diagnostic challenge case for our uveitis grand rounds. So to go into the story, we have a 77-year-old male who presented with vision loss in his right eye. In terms of medical history, is type 2 diabetes, hypertension, dyslipidemia. In terms of ocular history, not too much, just had a cataract surgery in his right eye about 10 years ago. So he presented with this progressive painless vision loss in the right eye for about a month, associated with floaters, and maybe described some mild pain around his forehead. In terms of his social history, immigrated from the Philippines in the 1990s. Sort of a vague historian, but on review of systems, nothing really stood out. No weight loss, fever, oral sores, back pain, hearing loss, tinnitus, rash, history of TB, or reported meningismus symptoms. And then when he was first seen in clinic, we saw that he had hand motion vision in the right eye, had a right RAPT, and pressures were within normal. An anterior segment exam, had about half plus cells in the AC and some cells in the anterior vitreous as well in the right eye. In the left eye, nothing too much, maybe some trace conjunctival injection, trace cells in the AC and in the anterior vitreous as well. So when we looked at the fundus, this was what we saw. So I guess I'm just gonna ask if any one of the residents can describe this fundus photograph.
Maybe we can go to one of the PGY3s. I'll just, in the interest of time, yeah, go ahead.
So it looks like a fundus photograph of the right eye. So I think a couple things right off the bat. Looks like there's pretty prominent optic nerve edema with significant peripapillary hemorrhaging. Also looks like just along that superior arcade, there might be a little retinal hemorrhage as well. And lastly, looks like in the macula, there might be a few kind of creamy yellowish colored choroidal or chorioretinal type lesions.
Yeah, exactly. So exactly what you said. Obviously, there's this severe disc edema, severe peripapillary atrophy, which is quite prominent. And in the left eye, nothing too much, can't really see it too much in this photo, but on clinical exam, there were some peripheral RPE changes as well in the left eye. So based on this, based on the history and what you see on exam, what would be the highest thing that you think about on your differential diagnosis at this point?
Maybe we'll ask one of the PGY5s to think about which categories and possibilities highest on the list in this differential.
Is Lily Tom there?
Yeah, if I had to pick only one, then I would probably worry most about something like leukemia or lymphoma, because it looks like there's bleeding and there's these creamy lesions in the retina, because I can't really put together the disc edema and the retinal lesions otherwise. We could consider like a severe ischemic optic neuropathy or something like that, given the disc edema, but it doesn't explain the retinal concerns. And then you could still consider the usual workup for the inflammatory problems. I think we already kind of discussed the workup at the last case. Yeah, because the other eye looked good, so I'm not really worried about like papilledema or something like that. And the patient is too old for optic neuritis or NMO.
Yeah, exactly. So the highest one on our differential was some sort of infiltrative process with all that optic nerve edema and the hemorrhage. And then there's other things on the differential as well. So at that point, investigations were initiated and the patient was seen in the uveitis clinic as well. There was subretinal fluid that was seen on exam in the right eye, and then peripherally there are intraretinal hemorrhages as well in the right eye, and RPE changes around the periphery as well. They also got some imaging, so you can see in the right eye, there's significant amount of subretinal fluid and RPE irregularity as well in the right eye. In the left eye, he wasn't complaining about any symptoms, so you can see some disruption of the RPE as well as in the photoreceptor layer in the foveal and the parafoveal area. So although he wasn't complaining about anything in the left eye, sort of like a bilateral process going on, although very asymmetric.
Jen, can you go back to the pictures just to illustrate that it was the one before, the slide before, to show that, again, just these, I'm not sure if you can show with your cursor here, that there were some changes in the RPE in the left eye. So even though it's presented primarily as a unilateral symptoms, there actually were some changes in the other eye as well. So that's important for later on and when we get to the diagnosis here. Okay, thanks.
And then we did IVFA as well for the patient. So you can see in the early frames, these pinpoint areas of hyperfluorescence and sort of like a Christmas tree pattern, and also optic nerve hyperfluorescence. You can see some irregular choroidal filling, and as you go through, you can see more pinpoint areas of hyperfluorescence that leak into the later frames, and there's significant optic nerve hyperfluorescence as well in the later frames. So you can see this continued significant leakage. In the left eye, you can also see that there's pinpoint areas of hyperfluorescence. They didn't leak as much, but you can see that they do sort of increase in intensity in the later frames. And then we also did FAF as well. So you can see that there's areas of hypofluorescence which correspond to the RPE changes that were seen on the clinical exam. And an MRI brain and orbis was also ordered for the patient. You can see in the left image on the right eye, there's some focal thickening and enhancement of the right optic disc, and then some mild thickening enhancement along the the posterior aspect of the right globe. So at this point, the differential diagnosis that we had for a posterior uveitis with optic nerve edema and subretinal fluid included the neoplastic processes like primary intraocular lymphoma or other sort of infiltrative lesions. Of course, there's the infectious conditions that are on our differential that we have to rule out, inflammatory conditions, including things like VKH, and then other things as well. So now knowing all of this and seeing all the photos, what are some of the investigations that someone might want to order?
Maybe we'll go back to one of the fours.
Yeah, at this point, I would consider doing a full uveitis workup, including the most common infectious cause, syphilis, TB, toxoplasmosis, herpes virus, and because the suspicious for lymphoma, we can consider doing a vitreous biopsy to look for lymphoma cells. And then there are other laboratory tests can be done for lymphoma, like IL-10 to IL-6 ratio, the DNA rearrangement of, and then also the myeloid proliferative gene can be also be tested. There are a couple of them, and but unfortunately in our system it's not commonly done as far as I know, and yeah, and then if intraocular lymphoma is considered, we can also ask neurology for a consult. We've been doing LP.
So the other consideration that I don't think we highlighted earlier under neoplastic is that could this be metastatic disease? So what would you do to rule that out, to investigate?
And then we'll do check 6-way to look for lung cancer. Is it female or male? Or breast cancer for male? No, breast cancer for female, and also if age appropriate. So then prostate cancer is another target to root out.
Okay, that's great, excellent.
Yeah, so some of the investigations we had, most of them came back within normal limits. You have your infectious type workup, generally negative, and autoimmune workup, which is negative. And to rule out metastases, did a CT chest, abdo, and pelvis, which was clear. So at this point, we ruled out a lot of infectious etiologies, and our provisional diagnosis at this point was VKH versus some sort of ocular of CNS lymphoma. And so just shifting gears a bit to talk a little bit about VKH and PIOL. As most people know, VKH is an autoimmune condition, and you can get bilateral granulomatous panuveitis, and it can be accompanied by extraocular manifestations as well. So again, it can affect the eyes, you can have uveitis, you can also have dermatologic conditions like alopecia and foliosis, cutaneous and perilimbal vitiligo, and also auditory complaints like dysaceusia. Can present in like the 2nd and the 5th decades, and there are certain risk factors that are associated with it. Primarily, it affects pigmented races, so people of Hispanic background, Asians, Native Americans, Middle Easterners. There's also an association with HLA-GR1 and GR4, and women are generally reported as being more affected by men, but this varies with population, so this isn't like a catch-all statement that it affects women more than men. And there are certain stages that VKH can present, or it goes through 4 different stages. First off is the prodromal stage, which can occur several days before they complain about significant ocular symptoms. So things like headache, fever, dizziness, meningismus. They can have some oral pain and photophobia, can have some hearing complaints or dysaceusia, tinnitus, GI symptoms like nausea and vomiting. And they can have focal neurological signs that are listed there as well. And then we get into the acute uveitic stage. At this point, they might be complaining about blurring. Often it's sequential blurring, one eye and then the other, more photophobia, red eyes, eye pain. And things that you might see on exam are anterior uveitis, so often bilateral and granulomatous. If you look at the back, you can see a variable degree of vitritis. If you do some imaging, you can see some thickening of the choroid. You can also have optic nerve edema, as our patient did, and as you can see in the photo on the right. And you can also have subretinal fluid or CRSRD. So you can see in this picture that this one is very well demarcated. You can also have some changes in the pressure as well. If you have ciliary body edema or things like annular choroidal detachments, you can shallow the AC and cause elevated IOP, or conversely, you can have low IOP secondary to ciliary body shutdown. And then weeks after the uveitic stage, you can enter into the convalescent or the chronic stage. So you can have some extraocular manifestations like poliosis. You can see this patch of white hair from the lack of melanin. You can have vitiligo and Segura's sign, which is perilimbal vitiligo. You can also get these characteristic changes in the fundus. So because of the choroidal depigmentation, you can see on the left that you have this characteristic sunset glow fundus appearance as well. And then the last stage that VKH can present with is the recurrent stage. You see this panuveitis with exacerbations of anterior uveitis as well. And then here you might also be dealing with the sequelae of the chronic inflammation that comes with VKH. You can have things like cataracts, glaucoma changes or damage, choroidal neovascularization, and also subretinal fibrosis. So looking at imaging features of VKH, if you do fluorescein angiography in the acute stages, you can often see in the early frames that there are pinpoint areas of hyperfluorescence, which was also seen in our patients, that will leak with time and then can expand in the subretinal space and into areas of serous detachment. So you can get these quite large areas of leakage. In the chronic stage, you can get these diffuse pigmentary changes that give this characteristic moth-eaten appearance. On fundus autofluorescence, you can see things like hyperfluorescence in the macula or hypofluorescence in areas of serous detachment. In the chronic stages, it can appear differently. Sometimes it's normal, sometimes you can have hypoautofluorescence depending on the changes in the RPE or RPE irregularity. Then OCT, you can see very characteristic changes as well. Often you see these areas of subretinal fluid, and you have septae within it that sort of separated into pockets of fluid. Sometimes you can see subtle choroidal folds on exam, and then you can see this on OCT with the corrugation of the RPE or the choroid, and you can also have choroidal thickening in the acute stages. So shifting off to things to think about when managing patients with BKH. Of course, it's always really important to have early diagnosis. So having a high clinical suspicion when you're looking at them on examination and ordering appropriate testing to get to the right diagnosis. In terms of the actual treatment itself, key things to think about or key things to aim for are controlling the inflammation and also preventing recurrences of it. You can use systemic steroids, IV or oral steroids. Some advocate for the use of immunosuppressants like azathioprine or cyclosporin, and of course you have to monitor them closely for complications or side effects. You can also have the targeted ocular management for the uveitis, like steroids and cycloplegics, or the injections of triamcinolone. And lastly, one thing to think about with management is how to manage the vision-threatening complications. We mentioned some of these like the cataracts, the CNVM, and the glaucoma. And so now looking really quickly at primary intraocular lymphoma, which is one of the other differentials which are high up on the list. It's the most common intraocular lymphoproliferative disease, and it's considered a variant of primary CNS lymphoma, which can occur as a primary vitreoretinal lymphoma or with CNS disease. And the majority are diffuse large B-cell subtypes, although occasionally you can get T-cell lymphomas. Women are typically more affected than men, and it generally presents in about 4th to 6th decade. So how do patients present? Very non-specific, blurring and floaters they often complain about, which again could be a lot of different things. If you look at them on exam, you might see some uveitis. You might look at the fundus and see that it's hazy because of the vitreous cells. In this photo, you can see that there are these yellow subretinal infiltrates with overlying RPE changes, giving a characteristic leopard spotting appearance. You might see some retinal hemorrhages. You might see some optic nerve head swelling if the lesions involve the optic disc. And with all of this, it's very non-specific, which is why PIOL is one of the masquerade syndrome. So when you see all this, there's a lot of things on your differential, like the classic inflammatory, infectious things, inflammatory, like autoimmune things, et cetera, et cetera. So it's a very long list that you have to consider in the differential. Some things that you might see on imaging, though, for specifically PIOL, you can again see on FA, there's this leopard spotting appearance with areas of hyper and hypo autofluorescence. OCT, you can see these granular subretinal lesions and these infiltrates. And on FAF, you can have different patterns. This one specifically shows areas of hypofluorescence, which are the lymphoma cells at the level of the RPE.
Let's just go back to the OCT here, because I think this case was a real diagnostic dilemma because of the age of the patient and the severe optic disc edema with hemorrhage, which wasn't completely typical of VKH. And we're considering whether this could be a case of primary intraocular lymphoma. But when you look at the features, and of course, hindsight is 2020, there's some features that were quite different in our case compared to, let's say, this, the OCT. So there's a few things that were different, when you look at the OCT here, there's areas, these elevations here, these subretinal elevations are filled with hyper-reflective material versus the hypo-reflective material, or the hollow looking spaces in our case, and which appears in VKH. So our case is more in keeping with VKH, we thought, but we weren't completely sure. Again, we were puzzled by the fact this patient was in his 70s, and usually VKH presents earlier on. Lymphoma will present, PIOL presents later in age.
So in terms of diagnosis for PIOL, gold standard for diagnosis is cytopathology of ocular fluid. And so you might see these large atypical lymphoid cells. You can also use immunohistochemistry, relying on the fact that most PIOLs are these monoclonal populations of the lymphocytes. Directed PCR is looking for certain rearrangements and mutations, and also cytokines. So Shava mentioned previously, looking at IL-10 and IL-6 ratios. But there are diagnostic challenges with PIOL. It's quite uncommon and rare. Again, it presents as a masquerade syndrome, so it can look like certain other uveitic entities. The importance of getting good sampling for with the diagnostic vitrectomies, meaning undiluted specimen, and also the samples are quite fragile. Lymphoma cells may necrose and be misinterpreted. So the diagnosis itself of PIOL is challenging in itself. So going back to the case and thinking about what was seen on exam, what was seen on imaging, and like as Dr. Driscoll mentioned with those OCTs, we thought that it was most likely VKH, although it's a very atypical presentation with some of the findings that we had discussed. But the patient was started on 60 milligrams of prednisone, did see some improvement, and then has been very, very slowly tapered, which is key for VKH. But because some sort of infiltrative process or PIOL was also still high on the differential, he was recommended to follow up with his family doctor to get an age-appropriate malignancy screen, still to be done. And we sent him for audiometry testing. He was a vagus historian and wasn't complaining about any ear or hearing complaints, but it turns out he did have moderate to severe hearing loss bilaterally. Again, he's 77. This could also be age-related as well. So if we go back to the case, this is what he looked like initially, just as a reminder. And after he started on steroids, after 1 week of prednisone, you can see that the peripapillary hemorrhage definitely improved, but there's still a persisting optic nerve edema. And then clinically, the subretinal fluid improved as well. So you can see this on the OCT. So this was the initial OCT that was shown earlier. 1 week after, you see resolution of that subretinal fluid, and 2 months later, no recurrence of it. So just reviewing everything together, again, this was more of an atypical presentation of BKH. So if we think about the case from the beginning, presented with blurred vision and floaters, very non-specific, but him being Asian, more leaning towards BKH. He was an older male, so that made maybe a malignancy more likely. He did present with bilateral inflammatory changes on exam, although he wasn't complaining about vision problems in the left, but with the imaging, you can see that there are definitely changes in the left eye as well. Although it was a very asymmetric presentation. The subretinal fluid characteristic is of VKH, and optic nerve edema can be seen in both, but what was very odd about this case was the significant amount of peripapillary hemorrhage, which, based on like a review of literature, haven't seen another VKH patient present with this peripapillary hemorrhage. So that was very, very atypical. No history of any malignancy, no history of like leukemia, lymphoma, granulomatous disease, so more in keeping with an inflammatory type issue. And then when we started him on steroids, although PIOL may sometimes like show initial response to steroids, this is more in keeping with BKH. So the question is why he presented so atypically for what is presumed to be a BKH. Some of the things are maybe because of the timing of the presentation, maybe he presented late. In some of the photos with the RPE changes in the left, sometimes it seems like sort of like a sunset glow fundus, so maybe he didn't present entirely in the acute phase of VKH. Just in some,
sorry, Dr. Missielli, to comment about why was there so much disc hemorrhage here? Because this is, as we say, this is very atypical to have this amount of disc hemorrhage and edema. Dr. Missielli, saw the case.
I think the disc, so this was a diagnostic dilemma when he first presented, like you stated. One was the fact that he had no really characteristic symptoms of VKH. He was older and it was so asymmetric. The hemorrhage is just secondary to the optic disc edema. So probably what happened is the optic disc edema increased in its severity, and then the central venous pressure was quite high, and then it caused rupture of the venous vessels on the disc itself. So we can see this in many different causes of optic disc edema, like papilledema or ischemic optic neuropathy, when the central venous pressure rises very quickly. So yeah, I agree. I've never heard of or could find a case with such hemorrhagic optic disc edema from VKH, which is why this was a dilemma. Also, the response to steroids is also a diagnostic test, because although PIOL can respond to steroids, it's not going to be that quickly. So within 1 week, you know, he had such a dramatic improvement. So that helps also confirm the diagnosis.
Thank you.
So just in summary, this was a diagnostic challenge, but key things that we can learn from this are, of course, doing a thorough workup. History and physical are, of course, key. Using ancillary tests like OCTs or FAs, and also just having like these deductive reasoning powers for patients who present atypically. And importantly, of course, the multidisciplinary teams were very important for diagnosis and management of this patient. The patient was initially seen by retina, then neuro-ophthalmology, and now has been followed in uveitis clinic. So these are always key things to keep in mind when assessing patients, especially patients that present atypically and that seem a bit confusing. That's the end of my presentation. Thank you for your attention.
Thank you, Jen. That was excellent. And thank you, Shabo. I think we need to wrap up very quickly because we're out of time, but Dr. Bakshi also saw this case. Any other comments, Nupura, that you would add?
I saw this case, I think, a little bit later after both of you had seen him, and I agree. I mean, when you look at the parts of it in isolation, like the OCT, you could say, okay, this looks like BKH, but then there were so many atypical features. And as I just put in the thread, in the chat thread, I think both of these cases are really great examples of how things seem very clear when we're presenting them like this. I know it seems so obvious that these are the diagnoses, but when you're seeing the patient in real time, you want to rule out infection, you want to rule out neoplasia, and there can be atypical factors, and we come in with a very broad differential diagnosis and try and narrow it down. And I think that at the, it seems much more confusing at the time, and as things evolve, a diagnosis becomes more clear. So I'm grateful to everybody we get to work with to help us solidify these diagnoses for these complex patients.
That's
Well,
definitely a team approach is helpful in these cases.
Absolutely. So thank you guys. Thank you to Shabo and Jenny for some excellent presentations. And thank you to our faculty, Dr. Bakshi, Dr. Dershko, and Dr. Michelli for helping supervise these talks. And thank you guys for providing such excellent subspecialty care to our patients. It's a privilege for our department to have such excellence. So thank you all. There's a link for this, the evaluations in the chat. Those are necessary for CME credits. We don't have rounds next week because we have a resident exam, but they'll resume the following Friday with Mike Wan from Sick Kids. So thank you, everyone. Have a wonderful Friday.
Thank you.